Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Today, we will be speaking with Sophie Bliddal, medical doctor and full-time researcher from the Department of Kidney and Endocrine Disease and Department of Gynaecology and Obstetrics, Copenhagen University Hospital, Denmark. At the end of this podcast, learners should be able to competently manage hypothyroidism in pregnancy. This podcast is part of the continuing medical education program entitled Hypothyroidism 2025, Impact on Reproductive, Renal, Hepatic and Cardiovascular Health, targeting endocrinologists and other healthcare professionals involved in the diagnosis and management of thyroid disorders.
Hello everyone, my name is Sofie Bliddal. I'm a medical doctor and full-time researcher from Denmark, and my main focus and expertise falls within thyroid function and reproduction in pregnancy.
What should clinicians be aware of when assessing thyroid dysfunction during pregnancy?
So it's very important for clinicians to be aware of the physiological changes that occur in a pregnancy. So these are unrelated to women with known thyroid disorders, but changes that occur physiologically due to the pregnancy. So most importantly, during the first trimester, there's a steep rise in the human chorionic gonadotropin levels. And HCG, the pregnancy hormone, is able to weakly stimulate the TSH receptor. And this will cause a rise in the thyroid hormone concentrations, and then by negative feedback, as you know it, a decrease in TSH. And this happens quite quickly during the first trimester. There's a large dynamic variation even from week to week. So in a healthy pregnancy, you will find that the T4 levels will increase and the TSH levels will decrease. This is important. Other factors that also occur is that the rise in estrogen levels will stimulate the liver to increase the production of thyroid binding globulins, and this will cause an increase in the total T4 levels that, when you come to the second and third trimester, will be approximately 50% higher than in the first trimester or pre-pregnancy. Other factors such as deiodination in the placenta and changes in plasma volume and enhanced renal iodine clearance will also affect thyroid function tests. So because of these normal adaptations to pregnancy, it's important to use trimester-specific reference ranges when you assess a pregnant woman's thyroid function. So this can be quite challenging because although trimester-specific reference ranges is the gold standard, they're not available in many laboratories. What you also need to be aware is that some of these changes in pregnancy will affect the assay you use in your laboratory. This is especially the case when you measure free thyroid hormones, so free T4 assays will be affected by the steep rise in thyroid binding globulin levels. And therefore, this makes it even more important to not only use trimester-specific, but if possible, laboratory-specific reference ranges. In an attempt to be pragmatic about the fact that most laboratories do not offer such pregnancy-specific reference ranges, the American Thyroid Association has suggested some universal cutoffs to be used during pregnancy. So for TSH, a healthy pregnant woman should have a TSH between 0.1 and 4 in the first trimester. However, there are no universal cutoffs suggested for T4 levels, and this complicates matters. We know from a study assessing different approaches that we will misdiagnose pregnant women if we use universal cutoffs and if we don't use the trimester-specific approaches. However, this will mainly affect women with a slight thyroid function test abnormality. So if you don't have your own trimester and laboratory-specific reference range, you must rely on knowing that the TSH will decrease during pregnancy and T4 levels will increase.
How should women with known hypothyroidism be managed once pregnant?
Yes, so because of these physiological changes that occur during pregnancy, we need to mimic those changes in women who are treated for hypothyroidism. We know that women who remain untreated and who have a thyroid disorder are at a higher risk of adverse outcomes during their pregnancy. Overt maternal hypothyroidism has been associated with a higher risk of miscarriage, of preterm delivery, and preeclampsia. And also in some of our older cohort studies, a higher TSH during pregnancy has been associated with a lower IQ in the child. So for these reasons, it is important to treat pregnant women with overt hypothyroidism. And when we do so, we need to target a TSH below 2.5 to take into account the increased need of T4 during pregnancy, not only for the mother, but also to support the fetal development. Especially during the beginning of the first trimester, the fetus will need some T4 transfer from the mother for instance, the neurological development and growth. And it's not until mid-gestation that the fetus is able to produce a sufficient amount, or at least to some degree a sufficient amount itself. So we need to support the pregnant woman with hypothyroidism in order to secure enough hormones for her and the fetus. By targeting a TSH below 2.5, this should be sufficient to ensure stable thyroid function. So what you need to do is also educate your patients that if they're planning for a pregnancy, they need to be aware that as soon as they're pregnant, this increased need for levothyroxine occur quite quickly. So it is part of the guidelines that a woman, even before having a thyroid function test, she could, as soon as she finds out that she's pregnant, increase her dosage of approximately 25 to 30%. In most cases, this is equivalent to just doubling the dose on 2 specific weekdays in order to secure sufficient levothyroxine. Now, we do need to be aware of the fact that it's also a risk that you could overtreat a pregnant woman. So if a woman is using quite a high dose of levothyroxine before pregnancy, or her pre-pregnancy TSH is quite low, she could also have her thyroid function tested as soon as she becomes pregnant, and this could help decide on the level of which dose increase could be needed. So this is an alternative approach. We need to target the TSH below 2.5, and the women should have repeat testing every 4 weeks until mid-gestation to secure that the TSH remains within target. Once the woman has given birth, she should be able to decrease her dosage again to the pre-pregnancy level. She could wait for a couple of weeks for the thyroid-binding globulins to come down, but you also need to repeat testing, for instance, 6 weeks postpartum, to secure that the dosage is still optimal. We know that some women will need a higher dose of levothyroxine compared to others with overt hypothyroidism. So this includes, for instance, women who have a thyroidectomy previously. And on the other hand, we know that the increase in levothyroxine could be less high if the TSH levels were quite low pre-pregnancy, or if the woman is taking a high dose of levothyroxine.
Traditional predictive factors for screening a woman for hypothyroidism during early pregnancy have been found to be unhelpful. What key factors would suggest to you that a patient should be screened?
Yes, so it is correct that we know that the risk-based screening approach, that is still the main recommendation in guidelines and also will be in the upcoming guideline, do have some flaws. So we know that we will not be able to detect all women with hypothyroidism by using this risk-based screening approach. However, it is still the main recommendation. And for the purpose of the upcoming ATA guidelines, we have performed some quite extensive systematic reviews on risk factors related to hypothyroidism in pregnancy. The most important risk factor for a woman to develop hypothyroidism during pregnancy is still the presence of TPO antibodies. So this has been known for many years that if a woman is TPO antibody positive, her thyroid gland will be less able, or at least be at risk of producing sufficient amount of thyroid hormones with the needed increase during pregnancy. So the problem is with this risk factor that you don't know if a woman is TPO antibody positive unless you measure it. And this is not a standard recommendation to do so unless you're treating women with infertility, where TPO antibodies would also be part of the screening program to also be able to know who to monitor during a following pregnancy. So other than the TPO antibodies, we do have other risk factors that suggest that each pregnant woman should be asked about once she's pregnant. So at her first prenatal visit, the physician should evaluate if the woman could be at risk of thyroid dysfunction during pregnancy. So other than the TPO antibody positivity, if she's known with that, the risk factors include if she has a previous history of thyroid disorders. This also includes if she had postpartum thyroiditis in a previous pregnancy or after a previous pregnancy. Of course, it includes also if she has symptoms of thyroid dysfunction, if she uses any kind of medication that could affect thyroid dysfunction, such as lithium or other drugs. And it also includes if she has a personal history of other autoimmune diseases, because we know that there is a great overlap between having one autoimmune disease and another. So for thyroid disease, this could include, for instance, type 1 diabetes or rheumatoid arthritis that are known to overlap with thyroid disease. Also, if a woman has a family history of thyroid disease, she would be more prone to developing a thyroid disease herself. So these are some of the more important risk factors. We have included for the guidelines also factors such as whether she has infertility or more than one pregnancy loss, of course also prior thyroid surgery or radioiodine use. So what is important to mention is that compared to previous guidelines, we did do a sub-analysis within the Consortium on Thyroid and Pregnancy. This is an international consortium investigating thyroid function test measures and pregnancy outcomes in cohorts based on healthy pregnant women without previous thyroid disease. And when looking into various risk factors, we did see a slight increase in TSH levels with age. So the higher maternal age, the higher TSH, and also BMI. However, the increased risk was very small, and it was not possible to recommend a specific cutoff for age or BMI that would entail a substantially higher risk of thyroid dysfunctions. Although these were traditional risk factors that we included as part of the risk-based screening program, these will no longer be part of the upcoming guidelines if approved by the societies evaluating the guidelines very soon.
With the current evidence, who should be treated based on the test results from risk-based screening?
Yes, so if you have measured a TSH in a woman without known thyroid disease based on this risk-based screening program, and you detect a high TSH, you should consider screening. There are some discrepancies between what we find to be abnormal if we apply our trimester-specific reference ranges and then what the large randomized controlled trials that are available have shown. I don't believe that any physicians would disagree with treating a woman with a very high TSH. And with a very high TSH, this was, as in previous guidelines, a TSH above 10. There is no doubt that a woman should start treatment to secure sufficient thyroid hormones for the fetus. However, we do now see some interesting new studies coming out. And one of the things I would like to share with you is that it's quite new that we now see studies that have tried to repeat thyroid function tests. And in women who just have a slightly high TSH, so just above 4, if we use that as a universal cutoffs, nearly half of them would have normalized TSH a couple of weeks later if we retested as we would normally do in a non-pregnant individual. So we suggest to also use this for guidance. So if a woman is not sure that she wants to start levothyroxine therapy and her TSH is only slightly elevated, just above 4, but still below 6, it is a new possibility to discuss this with the woman and consider whether you should repeat the test a few weeks later before starting treatment. Now, when I mentioned the cutoff of 6, it's because as soon as a woman has a TSH above 6, or especially if she also has TPO antibodies, the risk of the TSH being high when you repeat the test a few weeks later is much higher. So you should use this for guidance. So many of the large randomized trials that we have, an issue with those is that they started treatment in the second trimester or even in mid-gestation. And there are very limited evidence to suggest that, from the trials at least, that treating subclinical hypothyroidism just with a slightly high TSH has any benefit to the fetus or the woman. So one of the trials that we do have is the Iranian study by Nasapur's group. So in this trial, levothyroxine was started also in the first trimester. And from that trial, there was the finding that in women with a TSH above 4, and this was just with one measurement, there was a lower risk of preterm birth in the group who had been treated with levothyroxine compared to placebo. So these are some of the evidence that we do have from randomized trials. On the other hand, as you may know, the large NIH study and also the CATS trial, they did not find any benefits of treating subclinical hypothyroidism or hypothyroxanemia with levothyroxine. So one thing we also need to address is that more and more evidence are coming out showing that there could be a risk related to overtreating women in pregnancy. So we have this cutoff of 4, but we also see that in women who were treated with levothyroxine and had a TSH below 4, observational study from Dr. Maraka and colleagues showed that in such women, treating with levothyroxine had a higher risk of inducing preterm birth and also gestational hypertension and preeclampsia, whereas there was no benefit in reducing the miscarriage rate. So only women with a TSH above 4 in that study had the benefit of reducing the miscarriage rate without having an increased risk of preterm birth and preeclampsia. So this suggests to us that it is possible to overtreat women with levothyroxine and that this will lead to a presentation that we normally also associate with hyperthyroidism, such as preeclampsia and preterm birth. It's also worth mentioning that it does seem that some of the children treated in some of the large trials, the CATS trial specifically, where the mother had a high dose of levothyroxine during her pregnancy, they do seem to have a higher risk of behavioral disorders later in childhood. So there may be a risk related to overtreatment that we need to be aware of. And this is also why, as we discussed, the treatment target is a TSH below 2.5, but it should not be lower than 0.1. Just to briefly recap what I said. Women with overt hypothyroidism could benefit from treatment, especially if the TSH is above 10. If the TSH is above 4 but below 6, one could consider retesting before starting levothyroxine. This should also be based on the woman's own preference. But the reason why we are currently thinking that this could be an option to add to guidelines is to avoid the risk of overtreatment in those where the TSH would be normalized within a few weeks.
What take-home messages do we have at the end of this podcast?
So the take-home messages from this talk is that physicians evaluating thyroid function tests in a pregnant woman should be aware of the physiological changes that occur in pregnancy, and this includes TSH being lower in a pregnant woman during the first trimester, and T4 being higher, especially total T4 being higher in the second and third trimester compared to non-pregnant women. Further, one should use trimester-specific reference ranges and laboratory-specific reference ranges if at all possible. If not, a universal cutoff for TSH of between 0.1 and 4 could be applied. In women with known and treated overt hypothyroidism before pregnancy, the woman should increase her dose as soon as she becomes pregnant by approximately 2 more tablets per week. Close monitoring of her thyroid function every 4 weeks during the first part of pregnancy is important to avoid both over and under treatment. Also, universal thyroid screening is not recommended in pregnancy, but instead risk-based detection of thyroid disorders. And in that case, TPO antibody positivity remains the largest risk factor for thyroid dysfunction, but a list of risk factors are available in guidelines. Finally, who should be treated is currently being debated, but women with a high TSH above 10 should be treated immediately in pregnancy, whereas women with a TSH slightly above 4 could consider repeated testing before starting treatment.
Thank you for listening to this Medea podcast. For more information about our continuing medical education programs, please visit our website at medeaacademy.com.